Good morning, everyone. We're going to get started for our event today on using data to support better health care. I really want to thank all of you for getting up early and joining us today, and also want to thank all the people who are joining us online for our simultaneous webcast. I'm Mark McClellan. I'm the director of the Engelberg Center for Healthcare Reform here at the Brookings Institution. This is an important and timely topic on using data to support better health care. It may not sound like the most important topic with all of the debate about public options and subsidies and deficits, but as I hope you'll see during the course of the presentations today, this topic is absolutely essential to learning how we can make our healthcare system work better, and so it's probably the most important piece for getting to a healthcare system that's more sustainable and consistently delivers better quality care. Before I start, I'd like to recognize the generosity of the Robert Wood Johnson Foundation for supporting this event, for their ongoing support of the High Value Healthcare Project here at the Brookings Institution. And I'd like to again thank all of you. This is designed to be an interactive event. Following each of the panel discussions, we're going to take questions from each of you. If you've got a question, please raise your hand and we'll get a microphone out to you. If you're viewing on the webcast, you just need to submit your question online. And I want to remind everyone that this meeting is being recorded and is being webcast live, so everything we're doing here is on the record. What I'd like to do to begin with is start provide a framework for what we're going to discuss today, and that's how we can learn from patient care data. We have widely recognized that we need to be doing a better job of improving quality and lowering costs through better information available when people are making healthcare decisions. The advantages of better electronic information available at the time of patient care include reduced duplication of services, avoiding those duplicative lab tests or imaging procedures, more personalized care, so if a patient shows up at a specialist or at a different emergency room from where they usually receive care, it won't be such a big loss in terms of having the relevant information on what that patient's history is and what that patient needs, and that all leads to better decision making. It can all lead to quality improvement in patient care. That's why an underpinning of every major healthcare reform proposal is more reliance on a more effective electronic data system for helping to deliver patient care. But what's important to remember is that better data for patient care also provides a stronger foundation for evidence to improve care for groups or populations of patients. This gives us an ability to understand patterns of treatments that are being received. It gives us an opportunity to learn more about outcomes, including adverse events, complications, experience with care. It gives us a better opportunity to learn about the costs of different kinds of treatment options, different approaches to delivering care. It's the foundation for better evidence on how we can actually improve patient care at the level of populations of patients. So individual data can support individual decision making. Better use of that data in an aggregated fashion can help drive better decisions for all patients. Now, this is not a new concept. This is something that's been recognized by many of the leaders in this room and by the Institute of Medicine and a series of reports and activities around a learning healthcare system, for example. They've emphasized that it is possible or should be possible to generate and apply better evidence for making healthcare choices by providers and patients through the kinds of process that I've been describing. Viewing the use of data that is developed in the course of delivering care as a natural outgrowth of patient care that can help to promote innovation, quality, safety, and value in our healthcare system. And this is also something that's being done now, as you'll hear about more this morning, in the areas of drug safety surveillance, in the areas of measuring quality of care and reporting on it to help lead to better decisions by patients about where and how to get their care, in the area of effectiveness research, in public health reporting, and many other uses. We are starting to develop better evidence from the actual delivery of patient care. There are a number of examples of the kinds of questions that relate to these issues, like how do doctors' performance compare with others in the region? What are the best opportunities for improving care in our own institution, where evidence developed from individual patients put together can help us understand how to make better decisions, both as patients and as healthcare providers. In the area of patient safety, questions about whether particular drugs have unknown or at least not well-defined important side effects or complications, whether the H1N1 vaccine has an acceptable safety profile. In the area of effectiveness research, what about alternative approaches for therapies, like different ways of doing colonoscopy? What about different policy approaches? So not just questions of particular medical technologies, but if we change the way that we pay, if we provide support for a medical home, does that actually lead to better outcomes and lower costs compared to alternative policies that we might implement? All of these benefit from putting together data across multiple patients to help answer questions about evidence on quality, on safety, on comparative effectiveness. And so a very important question as we're making investments in healthcare reforms and making investments in our healthcare infrastructure is how can we best use the emerging electronic information systems to support all of these different evidence uses of patient care data effectively and also securely in a way that protects patient information and confidentiality. What kind of infrastructure is needed for these sorts of steps? Well, it's important to remember as we approach all of these different kinds of evidence questions that there actually are fairly similar data needs in many respects for all of these uses. For questions about safety, it's important to measure the treatments that are provided, the outcomes, the potential patient-level confounders that could also affect outcomes in a well-defined sample of patients, a well-defined population of patients. For effectiveness research, it's important to get the same kinds of information on treatments and outcomes and patient factors influencing those treatments and outcomes, as well as on alternative treatments. And in evaluating quality of care, again, it's important to understand care processes, treatments, outcomes like resource use and costs, data on patient confounders or risk adjustment data for a broad population of patients. It's the same kinds of data in all of these cases. And much of these data can be developed from systems that are now used to provide patient care. And looking ahead, as these systems get richer, the potential for pursuing these kinds of evidence questions can potentially get even better. Right now, there are many types of data systems used for patient care decisions, for individual decisions about particular patients. Data like information from insurance systems, claims data, which have the advantage of being a fairly well-defined population and including a broad range of services from a broad range of providers, basically everything that's covered in the health insurance plan, and it's all linked together at the patient level. As health insurance becomes more sophisticated, these insurance plan systems are increasingly relying on clinically sophisticated data as well, like lab results and things like that, not just administrative claims. Also, data from increasingly sophisticated healthcare provider information systems, so hospital systems, outpatient systems, physician office systems, which increasingly are being linked to other types of data to provide a better picture of care for the healthcare providers that are making decisions for particular patients. And, of course, a lot of growth in the use of electronic medical records now and projected over the next few years, which includes detailed clinical information and increasingly is also integrating patient data from some of the other sources that I've talked about. In fact, many providers are using registries, both for research purposes and for supporting patient care, information on groups of patients, such as all the patients in a practice with diabetes, that captures data explicitly from multiple sources to try to support better decision making, to make sure patients aren't missing lab tests and that abnormal results or undesirable clinical complications are being followed up on quickly. Lots of data being used for patient care that is increasingly sophisticated and increasingly integrated. If you think about moving beyond the level of individual patients, though, to summarizing these data, you get to being able to answer the kinds of questions that we've been talking about this morning around issues like quality of care and safety and comparative effectiveness of treatments. This kind of information on treatments, on clinical outcomes, on resource use and costs can be put together not at the level of individual patients. What matters for these kinds of evidence questions isn't so much was Mrs. Smith treated by Dr. Jones last Tuesday for her diabetes, but how many patients like Mrs. Smith were treated, what were their treatments, what were their results, what were their costs, using things like age and sex and disease comorbidity to group patients together, to provide a better understanding of how patients with different kinds of characteristics, how groups of patients with different kinds of characteristics are treated, and what the consequences of those treatment decisions might be. In fact, most of the evidence needed to develop better ways of improving care involves summary data, not the individual identified patient information. So for answering questions like, for example, does Vioxx increase the risk of a heart attack, the primary kind of information that's needed is not information on each patient like Mrs. Smith, but how many patients like her were treated with a particular drug like Vioxx or another set of treatments, and what were their results. Population-level results that need not identify individual patients. And this is a common theme that goes across all of these types of evidence development areas, quality, safety, comparative effectiveness research. Now, there is certainly individual-level data that are needed for making the right decisions for individual patients whose information is contributing to these broader population data sets and this broader ability to try to learn to get insights about quality and safety and effectiveness and other issues from the care of individual patients. For example, doctors certainly going to want to know which of my patients needs interventions to achieve better diabetes control, what are for making a decision about which treatment is best. Individual patient preferences are really important. And so I want to make this distinction between de-identified data or aggregated data that is what we primarily need for evidence from identified data or individual data, which is what we need for patient care. There's some connection between the two. For example, to confirm that a patient really does have a serious complication from, say, the use of a vaccine, it may be necessary to go back to the individual patient records, which does create the need for using identifiable information, at least in confirmation in some cases. But I want to make this distinction between data for patient care, which is behind local firewalls, which is used for operations of care and payment and improving decisions at the individual patient level, from this aggregated data that can be used to reach conclusions about important policy issues related to better medical evidence. And again, improving health care while improving patient care does not generally require sharing identifiable data. It's the difference between making decisions for individual patients from the importance of pulling together this aggregated information that can help us understand better ways to deliver care. We're using wires. We're using, within a particular institution, boxes of shared data. We're using data clouds of identifiable information to help improve individual patient decisions, but for purposes of these policy questions, these better evidence questions, what really matters is having the ability to use summarized or aggregated data. And that does mean some work. It means having common models for organizing and summarizing these data, standard terminology for getting information from individual sites and individual types of patients in a consistent way, and you'll hear more about that from our coming speakers in just a few minutes. This is a challenge today. Even though there is, I think, a great potential to learn more, especially as we become a more electronic healthcare system, to learn more about questions of quality and safety and better evidence on effectiveness of treatments, it does require overcoming a number of obstacles related to coordination and consistency. One way to do this is to try to set up a very large project that pools a lot of individual data and use that pooled data as a basis for analysis. But there's some real obstacles here, such as the participating organizations being reluctant to contribute identifiable information on their patients because of concerns about confidentiality and data security. And even if you put these data sets together from different sources, they may not be consistent, even if they're following the same standards, even if they seem on the surface to be about the same kinds of problems like diabetes or particular treatments. They may be coded or recorded in the electronic data sets in different ways. And it requires a significant central infrastructure. And if you're going to do this, it may be difficult to apply to multiple uses, like safety questions and effectiveness questions and quality of care questions. On the other hand, there have been a number of efforts launched in recent years that are more based on combining the aggregated data, not individual level data on patients, that stays behind organizational firewalls, but combining the summary information, which is not identifiable, but that can be used to get at these important underlying policy questions. Again, it's not data on whether Mrs. Smith went to Dr. Jones, it's summary information on how many patients like Mrs. Smith did doctors in a whole set of different institutions have. And if that information can be combined, aggregated information can be combined in a consistent way, well, then you can get the advantages of a large data set without actually having to pool identifiable and potentially sensitive individual information. And it also keeps all of the participating institutions actively involved in trying to make sure that their data are, in fact, consistent. There are a lot of examples of these activities underway now, and a lot of examples of activities to make these collaborations more powerful to the extent that they only involve one institution or one payer's data or one type of use of data. These are going to be less powerful. They won't be as powerful in detecting safety signals. They won't produce as precise quality measures. They may produce inconsistent results because they involve different populations or differences in methods, all of which are very difficult to understand without an effort to coordinate and support these kinds of activities. So a very important question is, can these kinds of efforts to learn from our healthcare system by pulling together summary data more effectively, can they be better coordinated, and how can that lead to more compelling results? There are multiple obstacles to developing this kind of evidence quickly in our healthcare system, even as we're becoming more electronic. Issues about access to the data, even if it's summary data that's not identifiable for patients, what information, what uses, under what conditions, making sure that privacy and security concerns, which are very important, are addressed, providing incentives for participation in this data summary system. It's very important, for example, to support better decisions at the individual patient level, ideally the way that we pay for health care, and where we might pay more under health care reform for better quality care as opposed to more services, would also reinforce providing data that shows that care is getting better at the individual level by showing that the summary information from a broad set of patients are getting better results overall, that we're reducing the rate of complications for diabetes in patients like Ms. Smith, and paying more for that kind of care, and paying more for providing the kind of summary data that come out of it. We need consistent methods for reaching conclusions, and that doesn't mean just between different sites that may be contributing data on, say, questions of patient safety, but also consistent methods across studies of safety and study of quality that may involve similar patient populations and similar treatments. And of course, since these, as you'll hear more from Alan Garber in particular, since these studies are often based, or generally going to be based on observational, non-randomized patient populations, avoiding biases like from unmeasured confounding factors is very important as well. So a lot of obstacles to making this kind of learning healthcare system work, but a lot of opportunities as well. So moving forward, some key issues here, which I hope we'll have a chance to discuss further in terms of learning from healthcare data at the individual level that's aggregated or combined up to the level of populations of patients, is can we define the important questions and how questions may have common elements across different kinds of uses. For example, defining the kinds of treatments and outcomes that are relevant to safety questions related to drugs used in diabetes care may help us do a better job of understanding patterns of care that are relevant to quality of care and effectiveness of different types of practices for diabetes as well. Identifying sources. There are a lot of efforts underway, as you'll hear, for using aggregated data for questions related to safety. There are efforts underway for using aggregated data related to quality. Can we put these kinds of environments together in a way that enables us to answer both types of questions more effectively? Can we develop and apply consistent and effective best practice methods when we're summarizing data and analyzing these kinds of de-identified data? Once again, there are likely to be some common insights from questions in safety, questions in quality, questions in evaluating effectiveness, questions in evaluating public health issues. And how can we best support these efforts? Can we align the incentives and support for improving patient care, these individual level decisions, for example, the upcoming payments for providers to use health IT to support the care of their own patients? Can we align that with incentives to support efforts to improve the evidence? For example, paying for better quality care is a key issue in healthcare reform. Well, it may be the case that the so-called meaningful use payments for health IT could be very well aligned with payment reforms that are aimed at the consequences of meaningful use of health IT, and that's better results for a population of patients being cared for by physicians. So again, it's about putting this all together. And finally, I think it's important to emphasize that we view this, at least, as a step-by-step process. There are many uses of data now. There are many different efforts underway to try to develop better evidence and to try to improve care at the individual patient level. Can we take at least some limited steps towards pulling together common elements of these multiple uses to build up to longer-term progress? So those are some of the issues that we want to cover in our discussion this morning, and I'd like to move right to our first panel discussion to provide a little bit more concrete context and a little bit more meat on the bones for some of these themes. And that includes three panelists who we'll hear from right now. And that is Dr. Alan Dobson, who's joining us from North Carolina. I'm sorry, Alan, I seem to have gotten my notes a little bit out of order, but if you could come on up along with the other two panelists, as well as Dr. Richard Platt from Harvard Medical School and Harvard Pilgrim Healthcare. Dr. Dobson is going to talk, and Dr. Alan Garber from the Department of Veterans Affairs and the Center for Health Policy at Stanford University. Dr. Dobson is going to talk about some applications in North Carolina related to improving quality of care. Dr. Platt's going to talk about the infrastructure needs for medical product safety surveillance, some of the safety issues that I alluded to earlier. And Dr. Garber is going to talk about data and infrastructure needs for comparative effectiveness research. After they give a brief overview, we're going to turn to a panel discussion and hope to hear a bit about some of the common themes that are emerging from all of these areas along the lines that I was discussing in my opening remarks. So, Alan, if I could turn this over to you. Thank you. Help with getting your slides up.
Thanks, Mark. It's a pleasure to be here. Got it. Talk a little bit about application of data from a practical standpoint as far as moving the quality agenda forward. And I'd summarize it in just as a simple thing. It requires a uniform effort on behalf of the delivery system, the providers, and some use of some standardized data. whether it's aggregated or individualized patient data. And just we're talking about data, but I want to put in there that it really requires a uniform effort. It requires provider engagement, a commitment to do what's necessary at the local level and at the physician-patient level to really improve our delivery system. Also, we need to recognize that local healthcare delivery systems are very, very different across this country. And so we need to focus on what we can do at the local level and improve the coordination. Also recognize that to really move quality forward, even with data, it's going to require additional resources, or at least reallocation of resources at health system levels, or in the case of primary care, which I think is going to be crucially important in dealing with chronic disease and prevention, that additional resources are going to be necessary to get the job done. And focusing changes broadly, if we can get an engaged workforce around responding to data and applied broadly across this country, really can produce significant results for us over the next few years. The other key part is standardized data so that you can compare apples to apples. And that should be multi-payer. It should be quality data that's all patients. And we can start with claims data, which is the most readily available, as we build infrastructure for a robust data system. But beyond that, it needs to be timely and actionable. In other words, we need to look at data, but also be able to provide the infrastructure to feed it back to the providers so that it can be actionable. It doesn't do any good to say that we only get it right 70% of the time if you can't tell the people what the other 30, which patients needed additional care that didn't get it. In North Carolina, we use community and practice level reporting rather than individual physician level reporting, and that's mainly because the delivery system is really a team sport, and we talk a lot about that. It's also a limitation of the data we have because we started in Medicaid doing this. The other part is transparency, which produces accountability, produces a new level of competition, not related to price or consumer choice, but that around providers seeing who can be the best and move the ball forward. Community Care is the platform we've used in North Carolina to get collaboration among providers and use our data. And it's a statewide program. We started with Medicaid, but its focus is on quality, utilization, and cost effectiveness. We have 14 networks, about 80% of all the primary care physicians, all the hospitals, health systems, and public providers managing 1 million Medicaid recipients. But we're now moving into, because it really is a delivery system model, not a payer model, and we're moving to other populations. We started with the major diseases that we saw in Medicaid: asthma, diabetes, congestive heart failure. But one of the things I wanted to point out is that taking the Medicaid database, you can produce aggregate data. And we created a data center, and we feed information back to each of our networks and then to each of our practices based on their real data. This actually shows average hemoglobin A1C values because the providers wanted more specifics than basically a process measure. Did you do it or did you not do it? They wanted to know what the values were. But if you'll look across our networks, we have some networks who are doing very, very well in a Medicaid population, which is hard to manage, probably comparable to a lot of the commercial populations in the country. So we're actually seeing some improvements from that standpoint. We've lowered asthma admission rates simply by using that data and feeding it back. So aggregating data, doing reports, and then feeding actionable items back to the networks and the providers in a way that they can act on it. We've lowered hospital admission rates, ED rates for asthma, improved compliance on medications, and we're slowly moving diabetes care forward. The big thing is our providers want not only the aggregate data and report cards, but they want actionable data fed back to the networks and the practice levels. We're using that by, giving them pharmacy claims. But the networks, a lot of them have taken upon themselves to make an agreement with their local hospitals to have real-life feeds on emergency room admissions and hospitalization so that they can then actually move the quality needle forward. Some of our larger health systems have invested in the technology of exchange inside the firewall, where they can actually, and this is an example of my institution where we have 45,000 diabetics. That's a lot of diabetics in the Charlotte region, and measuring each of our networks, and every quarter with not only actionable data but aggregate data to move the ball forward. Likewise, looking at those who are falling out of care and have not been, we're seeing a steady improvement in that information. This collaboration in North Carolina around providers and hospitals led the Hospital Association, every hospital, to go to create a Center for Hospital Quality and Patient Safety, where even the smallest hospital, rural hospital, and our big academic centers are measuring core indicators around diseases and making it transparent. And this is a all-or-nothing score system. You get all the care right and all the indicators that are agreed upon for heart failure, or you get a 0. If you miss one, you get a 0. So this is really providing the best care all the time. And you see, just by this public reporting and then creating actionable data at the hospital level, we're moving the quality bar forward. So I think to summarize the data elements we really need to get quality improvement is patient-level data, helping identify the gaps in care that need to be addressed, opportunities to look at transitions and avoid readmissions and duplication, as Mark said, but also putting out in front provider performance summaries. And this is not a report card about who's best. This is trying to raise all boats and provide complete standardized objective data sets. The thing that needs to be pointed out, and I think our next speakers will speak to that, is once we show that one community is doing better, the question is, what are they doing? What is best practice, and what are the elements that go into making that practical and duplicatable across the country? I look at it this way. You have claims, you have data from claims and clinical data. They're either process or clinical measures. The best we've got is aggregating those into quality reports and hopefully spitting out something that's actionable on the back end. The end result is something in the business world you call a lag indicator, is that if we do what's right, the lag indicators, we're going to actually get better outcomes at better price. So a final comment is that we need to use data to really get some systemization around our healthcare system, recognizing that healthcare systems are local, and it will require local physicians and healthcare providers and their communities to address it. HIT alone cannot fix the quality problem. We do have to build our primary care system out, and additional resources will be needed. But a uniform effort around quality and some real standardization of data so we can compare apples and apples and actually do the research necessary to define best practices necessary. But in addition to aggregate data, we need actionable data fed back to the local level to really define those gaps in care. And I would tell you that transparency in this framework will foster a whole new level of competition around quality versus just cost and volume. Anyway, thanks for the opportunity to be here.
Thanks very much, Alan.
Although my assigned topic was to talk about medical product safety evaluation, I see this topic as part of the larger field of public health uses of electronic health data. And so, while the worked example often is drug safety, I think it's important to think about the other ways we should use data that arise from the delivery of healthcare. The handouts have some bonus slides that I'd encourage you to take a look at afterwards that provide some extra detail about the ways to use these. The opportunity has already really, I think, been laid out for us that data that arise from the routine delivery of healthcare can be useful in a variety of ways that serve a public health purpose. That includes identification of adverse events of drugs and vaccines, cases of notifiable diseases that are of interest to local health departments. Syndromic surveillance, for instance, being able to monitor the occurrence and propagation of influenza or other conditions. And yeah, okay, how's this? And also other conditions that are of public health interest. For instance, understanding where diabetes is most prevalent in communities, so that interventions can be targeted that way. Now, I'll show you very quickly some examples of post-marketing safety for drugs and vaccines that are being conducted now. So this is not a speculative venture. The FDA sometimes uses a list of designated medical events that are conditions of most interest to identify among marketed drugs. I've shown on the left are examples that I know from my own experience have been addressed using routinely collected health data. The ones on the right I don't know haven't been, and I think many of them are tractable using electronic health data combined with a very limited amount of review of original medical records. We'll come back to the importance of medical records availability as a key component of the medical safety evaluation situation. These are other kinds of outcomes that for which there has been success in using electronic health data. The ones on the left are a potpourri from the published literature. The ones on the right are ones that the Observational Medical Outcomes program is evaluating using electronic health data. Even as we speak, there are active programs doing real-time surveillance for adverse outcomes of the H1N1 vaccine. One large program is being conducted under the auspices of the Vaccine Safety Data Link. The other is called PRISM, uses data from 4 large national health plans. These are the outcomes that are being evaluated. All of the heavy lifting is being done by use of of electronic data systems from health plans and from large payers. The Vaccine Safety Data Link has active surveillance programs using near real-time data for these additional outcomes. So the sense I'm trying to give you is that there is fairly robust evidence that it's possible to use these data for other kinds of conditions under a Center of Excellence grant from the CDC. My colleagues and I have developed a real-time system for detecting and reporting the conditions on the left here, and those are individually reported conditions and aggregate conditions like those on the right. So if you step back and ask, what do you need to make these things possible? I'd say that for doing medical product safety assessment, you almost always need to be able to identify the defined population that Mark talked about. And that means typically there needs to be something like a health plan substrate so that you understand enrollment, demographics, have access to claims in inpatient and outpatient settings, pharmacy dispensing data, and access to full-text medical records. Why is that important? It's important in order to be able to confirm the accuracy of relatively unusual outcomes that are not coded with perfect fidelity, or to collect additional information that is rarely available in electronic forms. Data about a patient's history, for instance, or information about other kinds of risk factors that may not be coded. The need here is typically to be able to access a few hundred records out of millions that contribute to the underlying evaluation. So I'll show you an example in a moment of a study we've done where we started with the electronic with electronic health data from about 50 million people, and we ended up reviewing about 500 records, but they were critical to being able to have to understand the outcome. Now, it's also often helpful to have access to electronic medical records, and it's increasingly worthwhile to be able to link to external registries such as birth and death certificates or to immunization registries. Now, for the public health reporting kinds of activities, there are many useful things that can be done without all that data. What's often most important here is demographic information and electronic medical records that provide information that's of interest to health departments, even if it's not coming from a defined population. It's sometimes, however, necessary to have information that is often not in the electronic medical record of a single practice, such as care delivered outside the practice, treatments dispensed as opposed to treatments prescribed, and the same kind of external linkage. I'd like to show you quickly a couple of examples of work that my colleagues and I are doing. Much of our thinking has arisen from work by the HMO Research Network, of which my department and health plan are a member. Over the years, it's become apparent to us that there was real value in our developing a set of standards that allow each of the participating organizations to develop a identically formatted set of its own data. It's a virtual data warehouse, meaning there's no pooled data set, but in each of our organizations, the data are arrayed sort of like a Toys R Us. You can always go to aisle 3 and the fourth shelf and be pretty sure that what you'll find there is the same in each of the health plans. The data come from enrollment claims, pharmacy, electronic medical records, and external registries, but they're arrayed in a series of very simple tables that are linked by a common identifier. And this has been an evolving process with addition of new variables as time goes by. Various of us take responsibility for different kinds of tables. I lead an AHRQ, Center for Education and Research in Therapeutics, a CERT, and so we've taken the lead in developing the pharmacy tables. The Cancer Research Network, it's funded by the NIH's National Cancer Institute. It takes responsibility for the tumor piece of this, and so it's a shared activity from which all can benefit. We use these data for a variety of different things. That's what gives me optimism that the subject of this conversation today is achievable. For FDA, we do post-marketing surveillance as part of the Mini Sentinel program, and we have contracts with the Center for Drugs and the Center for Biologics. For ARC, we lead a CERT and one of the DECIDE programs that is focused on effectiveness. We lead a multi-center diabetes research consortium, the Cancer Research Network that I mentioned, and a cardiovascular research network. It's one data system that underlies this. Each time we tackle something new, we usually have to augment the VDW, but the core proves to be extremely useful to us. Here's the kinds of things that have made a difference in our work in medical product safety. This is work by the Vaccine Safety Data Link, which involves 8 health plans that are part of the HMO Research Network. About a year ago, there was a presentation to the Advisory Committee on Immunization Practice about a new identification of febrile seizures associated with MMR vaccine, a tetravalent vaccine. That came from a finding that from active surveillance, I don't have a pointer, here we go, monitoring over time on a weekly basis, there was a signal of an excess number of observed events of seizure following immunization compared to the expected, and you can see here that was occurring with a relative risk of just about a 2-fold excess risk of seizure. Finding the signal wasn't itself sufficient to make a presentation to the advisory committee or for the advisory committee to change its recommended use of the vaccine, which is what happened from it. There was a substantial amount of follow-up evaluation that went through that, but it's really the first example of active surveillance leading to a change in practice. It's harder to do this work with drugs than vaccines. We've done a proof of principle looking at Vioxx and myocardial infarction, showing that that the data as they accrued in our system was capable of showing us a signal relatively soon after the drug was dispensed. And it's possible to apply these techniques in large national systems that cover a substantial part of the U.S. population. This is a study that we're just completing of meningococcal vaccine and Guillain-Barré syndrome. It involves the 5 health plans on the left. They have an aggregate population of 50 million. We're targeting, that's a vaccine that's used in adolescents, and it's covered about a quarter of the U.S. population of adolescents. We use distributed methods, having each of the participating plans develop, in effect, a temporary virtual data warehouse for just the data involving these individuals, and we're able to come to a successful conclusion of that work. I'd like to take just a second to say that in our public health informatics work, we've developed an operational system for doing notifiable disease surveillance, detection, and reporting to the health department. I'll let you read more about that in the notes, but it does better than manual reporting. In conclusion, I'd say that we're convinced that there are a substantial number of safety, effectiveness, and quality questions that could be answered by using electronic health data. One of the things that has really become very clear to us is you only need a very small fraction of the kinds of information that are in either clinical or administrative data systems. And so it's not necessary to inhale everything that's in these electronic data systems, which is what has made our work possible. We believe that because you don't have to deal with everything in those systems, it's much more tractable to develop distributed data networks, and that avoids many problems having to do with both confidential and proprietary data. The way that distributed networks can work is by adopting a common data model, and our experience with these models is that they have to evolve over time, that no matter how carefully we think about it now, we'll think differently about it in 6 months. So I think that a way to proceed would be to think about developing a core common data model where we would standardize the definition and format of elements that are useful to at least two of the disciplines that we're talking about, with each discipline taking responsibility for the things that are unique to its own work and contributing that to the larger set. And that I want to emphasize the fact that this is a simpler task than dealing with all of HIT. And so in the spirit of making progress quickly, we should make sure to look for the light touch rather than having to do the heavy lift. Thanks.
So I don't know about the rest of you, but my handout was missing pairs of slides, every other pair of slides. It might be a nice exercise in whether we really needed all of these slides for those of you following around, but I'll at least be happy to make my full set available to everyone, and I'm sure the Brookings people can help out with that. I just want to make a few brief comments today about how healthcare databases can contribute to the comparative effectiveness research effort. And when we're talking about these databases, we're generally talking about observational analyses, which is really what Rich and Alan and I have talked about, and Mark as well. In observational studies, I just want to review very briefly. I'm sure this is familiar to all of you. There are several compelling advantages, the most obvious of which is cost. Once you have an electronic database set up and a way to query it, the cost of doing a study is much, much lower than for an alternative that is custom designed, usually a study like a randomized trial. You can have access to an enormous number of observations, as I think was particularly clear with the databases that Rich was talking about, but also Alan. And that means you can answer questions that simply aren't possible in other settings. Speed. We talk in medicine about the prospective study, the prospective randomized trial. In fact, we often do what's sometimes called historical prospective studies, which have the statistical characteristics of studies that you start out today and follow people for a long time, a true prospective study. And you can query a database by setting up this study properly and instantly have 5 or 10 years of follow-up because you're basically going backwards in time. Simply not possible with a genuinely prospective study. Real world. In the world I live in of medical care, we actually have patients who don't take their medicines when they're supposed to. And most of my patients would be ineligible. I practice in a VA hospital, but it's true of many other practice settings. Most of my patients would be excluded immediately if they were screened for a randomized trial. They'd have to agree to show up for a lot of visits at a scheduled time, get a lot of tests, and so on and so forth. Your typical randomized trial patient is simply very, very different from your typical patient, period. In fact, a common number that you will hear is that roughly 5% of the people screened for randomized trials are actually enrolled. So this is really about capturing the other 95%. The other thing, which I'll mention briefly later, is in the real world, the interventions that patients receive are not necessarily the same as in a trial. It's one thing if you're talking about a drug trial where you have a pill with uniform characteristics from person to person, but what if it's an operation? What if, in particular, it's a very complex operation and you have surgeons with varying experiences, some of whom do an operation 5 times a year and some of whom do it 200 times a year? You get very different results. And who enrolls in the trials, who participates in the trials? You're typically going to see the surgeons who are doing 200 operations a year. One of the great advances, and Mark has talked in some detail about this, is the databases assembled from electronic health records. They're different from what we've worked with before because they have extraordinarily rich detail about the patient's characteristics, the doctors, the facilities that patients are treated in, and that really extends the horizon tremendously for appropriate use of observational studies. Now, this last bullet point I have, in some circumstances, statistical methods can adjust for bias. I don't want to get in the weeds here about methods, but methods are crucial. ARC, in fact, has been a major supporter of efforts to improve methods. Other federal agencies have as well. FDA has actually worked on this also, as has the VA and NIH. But Mark would not talk about this too much today, but he used to be a very promising young academic, and his dissertation actually used a novel method, novel at least in the health world, called instrumental variables to find out what the effect was of having access to open heart surgery and hospital facilities that could actually provide cardiac catheterizations for patients having heart attacks. And he was able to analyze what the effects were of having being more likely to get treated with one of these procedures because you had your heart attack somewhere near a major facility that offered these kinds of resources. That study really, it's hard to imagine how this could have been done in a randomized trial framework, and it was very convincing about effectiveness. So that's the kind of thing you can do. So these are used more broadly as complements to formal randomized trials. There are many, many questions that can be addressed that can't really be addressed by randomized trials. Alan has talked about quality improvement and how these kinds of data can be used. I won't talk more about that. Rapid implementation. And if we develop the infrastructure, and this is part of what the National Healthcare IT Initiative is all about, if we develop the infrastructure, the cost of accessing these kinds of data rapidly and in large scales will go down dramatically. And this is already being, not quite sure how that happened, but okay, I got it. So you need to extend my time by 30 seconds there. Thank you. And there are sometimes actually when you can't really do the study at all without observational data. So I just mentioned Mark's study, which I don't think you could do very well with randomized trial. Sometimes you can't randomize patients. There are all kinds of reasons why that might be true. Accrual, by the way, is a huge issue for randomized trials. With observational studies, you look at what people actually got. But sometimes it's unethical because you actually think denying a particular treatment that you want to study would not be ethical. In the real world, people don't get that treatment for all kinds of reasons. So you might be able to learn something outside the randomized trial. I alluded to treatment adherence. I am told that for, say, HIV drugs, once you get below 70% compliance with the treatment regimen, it basically is completely ineffective. You look at the people in trials, and they have near 100% compliance. You get a very different picture of how the intervention works. I already mentioned surgery. And think about analyzing the effectiveness of diagnostic tests. It's pretty easy to figure out if a diagnostic test is accurate. A new diagnostic test is more accurate if you have the right circumstances, but those circumstances often apply. For example, you have a way to confirm the diagnosis. But what if you want to know if a newer diagnostic test actually improves health outcomes, lowers mortality, reduces hospitalization, and so on and so forth? There are very few trials of that kind, because embedded in that trial has to be an assessment of the treatments that you administer based on the diagnostic test. And that you may get a very small number of people with the disease in question where you expect treatment to make a difference, and the number of people needed and the length of follow-up needed can make a trial prohibitive. This is something that you can do much better with observational studies. So I want to just point out some data. In the world of randomized trials, they are considered the gold standard in terms of evaluating whether an intervention works. And I do believe that myself. But you have to ask, how do they compare where we have data from both? And let me just show you, this is from a study published in 2000 in the New England Journal of Medicine that looks at 5 different questions, if you want to call it that had been addressed by both randomized trials and observational studies. And this may be too small in your handouts to see, but the light dots give the results of observational studies, and the dark splotches are the results of randomized trials. So these are for, as I mentioned, 5 different situations, a vaccine to prevent TB. And what you see is when you have the benefit, if you want to call it that, of multiple randomized trials, the results vary quite a bit. And then you look at the range of results of the observational studies. In this case, they're sort of on top of each other. Mammography and mortality from breast cancer. The observational studies showed slightly greater benefit than you saw in the randomized trials. The cholesterol levels and death due to trauma, this has been a highly contentious issue, and you can see why when you look at how widely spread those splotches are. Treatment of hypertension and stroke, an outlier study that was randomized trial, but otherwise the observational studies give you similar answers. And same thing with treatment of hypertension and coronary heart disease. The bottom line is observational studies vary, randomized trials vary in terms of their results, but the ranges typically overlap. Here's another study by a different group that looks specifically at cardiology, at cardiac treatments. And I'm not going to go through these in detail, and all you really need to see is that these bars are right on top of each other. The dots are the central estimates of the treatment effect, and the ranges are given by those bars with the little things at the end. And what you see is that the observational studies, with the exception of this study of Cabbage, the fourth one down, there's just overlap. It's not really that close, but you also see that the randomized trials had a wide range of results, and there's little confidence in the results. So particularly when you look at cardiac treatments, the observational studies have tracked very well with the randomized trials. Now, this doesn't mean that all observational studies are good. And there's an art to it. And you happen to have here people like Alan Dobson and Rich Platt who are doing path-breaking work. You can get very reliable results, but you can also get lousy results. So one of the things that helps a lot in being able to do a good study is if you have a lot of clinical detail. So I've just listed here some of the things that you would typically need to have a good study in that respect. Now, I'm going to just mention 2 examples very briefly of successful use of observational databases built from electronic health records that have this kind of detail. This is from a Kaiser study. So Kaiser Permanente has long had electronic health records, and they've had the ability to query them in order to do studies. And this study, if you'll just look at the left column of results to angiography necessary, what they've looked at is people who met these guideline-based criteria for having it being appropriate to receive angiography, people who had heart disease or were suspected to have heart disease. So what they showed is that in hospitals that had a high rate of performing angiography, the mortality rate from heart disease was 2/3 as great as in hospitals that didn't. And if you look at any heart disease event, it was 70% as great. Now, the footnote, there's a lot of nuances to this. Part of the purpose of the study was to look at which were the good hospitals and which were the hospitals that needed improvement in the Kaiser system. But if you look at the bottom and it says what was in the model, this gives you an idea of what kinds of data you need to have a successful study of this kind. These are basically demographics, a bunch of diagnostic information, and some measures of the severity of the illness, as well as characteristics of the hospital. The VA also has electronic health records it's had for several years, and incidentally, the VA now has the ability, relatively recently, to be able to pool electronic health record data nationally. And so I think in the coming years, we're going to see an explosion in the studies coming from the VA, because you can tap into the entire patient population pretty much and get clinically detailed data. This is a study, a little bit complicated, but you've probably all heard about Plavix, this drug that is given to patients who've had stents and some people who've had heart attacks or angina. And there was an observation that wasn't very well supported at the time they initiated the study, that it seemed that people who were stopped, who stopped taking their Plavix, maybe under the doctor's instructions, would experience a high rate of heart attacks after it was stopped. And this is something you didn't really see in randomized trials particularly. So they actually took data based on the electronic health records at the VA, but they were supplemented by additional data and looked at the rates at which these events like heart attacks occurred in different time intervals after stopping the drug. And what it showed was, if you take a look at this left column, for example, the incidence rate in the first 90 days was about twice as great as in days 91 to 180, and the rate declined after that, suggesting that we need to be particularly careful about guarding against heart attacks immediately after stopping Plavix. This is, again, the kind of result you couldn't easily get from a randomized trial. So to close, just basically, I hope I've made the case that these are important complements to randomized trials. I'm not saying randomized trials are unnecessary by any means. I could also give you some examples where observational studies have been extremely misleading. But they really open up the range of questions that you can answer with good data. As Alan has gone into in detail, you can very easily tie the results of this kind of research into quality improvement efforts. You can implement these findings very rapidly. And as I mentioned, the investment in database infrastructure means the cost of doing these studies will likely fall dramatically in the coming years. Thank you.
Great. Alan, thank you very much. To open up the discussion, just to pick up on a point that Alan just made, the improved electronic data. Yeah, everyone's mics are right on the side of their chairs here, and you're going to need that for the audience to hear you. Rich, if you don't mind, I'll ask you a question while you're putting the microphone on. Alan was just saying about how the capacity to do these kinds of studies really does seem to be increasing rapidly. You've been on the leading edge of a lot of those activities. You mentioned at the end of your talk that a good place to go next might be to define a set of common data elements or models that could be used more productively across many different kinds of applications, not just quality, not just safety, not just effectiveness, but potentially in a broader range of areas. I was wondering if you could say a little bit more about that. What might be involved there, just to get concrete? And if this really is becoming a routine part of the use of healthcare data, is it really research? Is this something that's more part of routine delivery and improvement of care?
Yeah, so let me start with the second part of that. I think in some ways we are doing a disservice by using the word research. We ought to call it evaluation because the superstructure we have built to supervise research doesn't serve us well. And it communicates, I think, the wrong message to the whole society. I think we need to change the normative expectations to say all of us should insist that our data that is part of these systems be used for thoughtful inquiry and evaluation and improvement. And we shouldn't call that research. It needs oversight, but I think it doesn't need the kind of oversight that accompanies sort of truly novel therapies that have not been tested. In terms of what we can, some of that is a matter of degree. I'll say, for example, this PRISM study that I mentioned, the H1N1 vaccine study that's going on now, is the very first study that I've been involved in that's been defined as public health practice rather than research. And it's made a huge difference in our ability to bring health plans on board and to link the health plan data to state immunization registry data. Very important. If we did it as a research study, we'd be able to tell you next year what the safety profile of the vaccine is, but that doesn't help very much this year. In terms of what we might do as next steps, I think the notion of developing sort of reusable data systems is a very powerful one. It's been the case for the last umpty-ump years that every time we start to do an observational study, we go and build a data set from scratch, and it takes a long time and it's expensive to do. And part of the notion of the virtual data warehouse is to say at least some of this should be reusable. And to be very honest, we started by saying what's commonly available and familiar to most organizations. That's claimed it's the kind of data that CMS insists that every organization provides. So if you look at the actual data structures of our virtual data warehouse, big sections of it look like claims data submissions that organizations make to CMS. We would still live with that notion of saying start with the things that almost everybody has or is familiar with, and then build the additional ones as needed. And it is really startling how much you can do with how little in terms of the kinds of data elements and what you need to know in them. In a healthcare delivery system, a functioning delivery system, it's important to really understand and be able to distinguish between probably 90 different venues for delivery of care. In our work, it's unusual that we need to know more than ambulatory emergency room inpatient. And so not having to keep all 90 of those in mind is a big help and makes the overall job a relatively simple one. And it makes me think that it's worth starting now with the notion that it's a semi-disposable system that we're building because you should be able to tear it down and build it up as needs change and as data capabilities improve.
Alan Dobson, picking up on this point that Rich made and Alan Garber made about how if we do this carefully, we can get a lot of mileage for a limited amount of resources. One of the things you emphasized was that it's still difficult. It still has there are costs associated with providing this kind of infrastructure, financial costs, and also costs in terms of just broad participation from providers. I wonder if you might say a little bit more about some promising models for how these kinds of costs for shared data uses for multiple purposes could be overcome, both in terms of bearing the financial costs and in terms of bringing the providers along. You emphasized in particular the importance of feedback that actually improves patient care. Not, to pick up on Rich's point, not something that gets published in a journal next year, but something that can affect patients right now. Are those the ways to go to make this more sustainable?
I think there's 2 points that one that Rich made, and I think Alan as well, is that we have to be more standardized in defining what the data elements need to look like so that they can be used, in getting standardization. The other part is the question is, do you build a centralized database or do you, I like the notion of, having it virtual if you can go get the data when you need it rather than redoing it. I think there is, an issue related to getting actionable data, which is protected. So the closer you can get to an operating unit that can actually do something, but yet feeding aggregate data up for research, it makes a lot of sense. And I think that it's extremely important that I think the federal government can take some leadership of defining those elements, but also, putting multi-payer. I mean, it really needs to be about all the patients we care for in a community and at a practice level. That starts to make it more economic when you start talking about doing actionable steps and creating a delivery system model, because the real cost is really changing the delivery system. The data ought to be, if we build it right and thoughtfully, ought to be very cost effective when we start putting more and more people into it.
Thanks, Alan. And Alan Garber, just picking up on these last points, we've got, as you know, an ongoing healthcare reform debate here in Washington. I was reminded of, in the discussion this morning, of a political cartoon recently where somebody's watching their television and announces that, and the Senate is about to begin debate on healthcare reform. Begin, after all. I think we're getting pretty far along in this debate. As we get into what may be the final stages, what's most important for this legislation to include in order to support the kinds of goals that Rich and Alan have talked about, in order to further, and that you have talked about, in order to further the development of this multiple-purpose infrastructure?
Well, Mark, am I allowed to ask about things that I know aren't in the legislation?
Absolutely. If this is the time
if I had my
link
wish
it back.
list as a researcher, or to pick up on Rich as an evaluator, there are many things that could be done to facilitate the research, and David Blumenthal is here now, and we could start with something that I know he's trying to do, which is to make sure that there are common reporting formats for these data elements. So I would like to see the comparative effectiveness research effort include some real investment in both methods for pooling data, statistical methods as well. Now, the methods for pooling data will include things like a common data reporting format, which I see as crucial. I don't, for quality purposes and for payment on the basis of quality, I can envision a world where we have an agreement about which data elements are needed. I don't think that will be the case for research in JUMP, because when we're looking at a very diverse range of questions, we're going to need different data elements. So instead, I think the model is a platform that we can build upon. So I don't see the federal government specifying what data elements are needed for research in any form. But I can see the federal government saying, you need to use a standard reporting format to facilitate this. So this isn't exactly what your question was about, but one of the things that comes to mind, hearing both Alan and Rich, is that I gave two examples of closed health systems. Virtually everybody in Kaiser Permanente gets all their care within the system, so everything pretty much is captured in their electronic health record system. It's somewhat less true of the VA, but it still is largely true of the VA that you get almost complete data capture. When you talk about integrating data across multiple providers who are in different networks or aren't in networks at all, you run into problems like, will the Eclipsys electronic health record be able to format data the same way that the Epic system will? And can you even get the vendors to agree to a common reporting format? And what about those practices that don't have electronic health records at all? So that's what the healthcare IT money in the stimulus bill is supposed to alleviate, and it'd be nice to think we'll get to 100%, but I suspect that won't really be the case. So I'd like to see the legislation encourage that, but on my wish list also that's not in the legislation is some clarification of HIPAA standards to ease the use of individually identifiable data. Because as Mark well knows, and I think everybody up here would agree, we can do at least as good, maybe a better job protecting patient privacy while also easing availability of data for research purposes. And I think that has been a major impediment. I know that's not a big part of the healthcare reform debate, but if we're going to make maximal use of this kind of information, it will be important to address that.
Thanks, Alan. I'd like to open up this discussion to some of you who are here, maybe some of you who are watching online. Any questions in the audience? Back here. And when you get the microphone, please do wait for the microphone. When you get the microphone, if you could tell us very briefly who you are. It's nice to see you here.
Good morning. My name is Ruth Perot. I'm the Executive Director and CEO of Summit Health Institute for Research and Education. Abundant research points to the importance of the collection of race, ethnic, and primary language data if we're going to address health disparities and also improve healthcare quality for those vulnerable populations. The most recent report came out in August, issued by the Institute of Medicine, and made that connection. Can you tell me or tell us what use and applications you've been making of race, ethnic, and language data in your work? You've all talked about demographics, but this is an extremely important component of the demographics. And we'd like to know a little bit more about how you're using it and the importance and value of that data.
Any comments? Alan?
Well, I'll just mention briefly, there's a huge amount of research being done with this, and you're raising the very important question of what are the causes of disparities and how can they be addressed. So I'll just give you one example of a study we did using Medicare claims data. So again, we don't have great clinical detail, but we were interested in why non-whites had higher rates of sudden cardiac death than whites in the Medicare population, where everybody, of course, has insurance. And it turns out one of the things we found is that there was a much lower rate of invasive procedures that are used to prevent sudden cardiac death. For example, in people who've survived an episode, yes, you can survive sudden cardiac death, by the way, but for people who have survived an episode, if you get an implantable defibrillator, you will live much longer. And there was a lower rate of those kinds of procedures being put in place. So I think most of us in the research community take it as a given that you absolutely have to have that kind of data, but we also see a clear path for using the data to better answer these policy questions, in essence.
Rich?
It's terribly important, but these data are usually missing in electronic health data. And so we usually...
What's missing is the details
the actual,
of race and ethnicity.
The individual's race ethnicity classification is usually missing. And that hasn't been an oversight. By and large, the practices and especially the large health plans whose data are so important have been reluctant to ask for that information or to capture it. That's starting to change, but for the time being, what we have had to do is to link addresses to census information and use census data as a proxy for race. So it's in the scheme of saying we need to have a change in expectations about the kind of data that are made available for use, goes along with saying it's important to improve care to have that information be part of the medical record.
Bringing the public along with this. Other questions up here? Oh, wait for the microphone, please.
Hi, Richard Singerman. I think you said a very important point about there is no be-all, end-all data model, and so to keep flexibility under registries. So I'm wondering, what kind of suggestions do you have for creating a meaningful use criterion for organizationally creating this minimal set of registries that have some sort of standard, but also build in the notion that every year from now, there's going to be a new technology that's going to make it easier and more effective. How do you strike that balance?
I think that being prepared for new kinds of data is in a way the simplest piece of the work, because if you imagine a structure of a series of linked tables that have a common identifier, when it comes time to add genomic data to the virtual data warehouse, we can build that table. So that part is pretty straightforward. The part that gives us pause is when it becomes apparent that we want to make an improvement that breaks the model. That is, if it becomes necessary to change the format of an existing table in the virtual data warehouse, suddenly the 1,000 programs that have been written already to expect the data to be in a certain format don't work. And so you make those changes only grudgingly. It's not the end of the world to do that. The Vaccine Safety Data Link developed its model in the mid-90s. And when same organizations built this virtual data warehouse that I showed you, it's somewhat different. Suddenly, for this H1N1 vaccine work that we're doing, we've got we want to do exactly the same analyses. We'd like not to, and there are two slightly different data formats, and we'd like not to have to write the programs twice. So what we're trying to do is very quickly write a translator from one to the other. And so eventually there'll be enough layers of translation that we'll say it's not worth it, we better start over. But for the time being, while we're finding our way along, we can use those kinds of ways to adapt to new decisions to old data formats.
Investments in translators. I have a question from one of our online participants. Andrew Croshaw asks, roughly 9 states have, through legislative authority, begun developing all-payer claims databases where all the claims data in a state are aggregated together and can be analyzed at the state level. If these databases continue to appear throughout the country, how are they going to relate to the other types of databases that we've talked about, either virtual or centralized? And I think this is part of just this general question that we've been pursuing about how do you standardize these different data sources enough, especially in the short term, so that they're comparable enough to do real analyses. I mean, state databases, all-payer databases, Alan, seem like a valuable source of information.
Yeah, absolutely. And the question is who sets those standards and can, I mean, I think that's a role for, governmental leadership is to set the standards for, so that we don't have to rebuild these databases.
And just to be clear, what we're talking about in terms of standards here is not what some people who have been in the IT field think of as like data element standards. We're really thinking about data use standards, that for all these multiple uses, the data sets are similar enough that they are
so that
comparable.
You can get an apples-to-apples comparison to be able to do it. I mean, I don't think, I think it's already been stated, you start somewhere and you build onto it. So I think it's really important that we do in these multi-payer data sets start, aggregating that so we can compare to one state to another. I mean, that's an inherent problem in the Medicaid programs. In the country, you see one state, and it's impossible to compare from one to the other because we haven't got a standard format. And I think this is the opportunity to do that and build on it over the next few years.
Well, I'd like to thank our panel. I know there's some more questions, and we're going to try to get to those in the next session, too. I'd like to thank our panel for getting this discussion started in a very excellent way. Thank you all very much. And without any delay, we'd like to move to our second panel of speakers, and I'll introduce them as they make their way up to the table here and ask all of you to get that microphone on the lapel or collar or someplace. And so as most of you know, we've got, most of you know the people who are here. Sitting at my right is Dr. Carolyn Clancy, the Director of the Agency for Healthcare Research and Quality. Next to her is Dr. Janet Woodcock, the Director of the Center for Drug Evaluation and Research at the FDA. And then at her right is Dr. David Blumenthal, the National Coordinator for Health Information Technology at HHS. And what we've asked these 3 federal leaders to do is to give a few minutes of opening remarks from their standpoint about what they are involved with in terms of implementing some of the steps to learn from our healthcare system to develop better evidence on top of patient care delivery. And they've each got a tremendous amount of activity going on. And then we're going to have some discussion following those initial presentations. As one might expect, with everything going on these days, they all have a very tight schedule. I know, David, you need to leave a few minutes early, so we're going to take that into account as well. But Janet, let me start with you. Can you take just a few minutes to talk about FDA's Sentinel initiative, where it is in implementation? Great. If you have some slides, we'll use those too. Where it is in implementation and how it's contributing to this kind of data infrastructure for drug safety, but that might also fit into some of these broader issues.
That's it. Okay, I just wanted to do this on slides because it's not just Sentinel. And let me just say that FDA and, of course, many agencies have been doing this for years. But as Rich Platt said, it's always one-off. We get a study together, we find a healthcare system, we set up a pharmacoepi study or what have you, and then we do the work. And several years later, we have the answer. Okay, and that's not good enough in today's world. And as everyone has said, there are new opportunities that are existing because of the electronic health data. There are multiple examples now of trying to do more real-world, real full real-time analysis across multiple healthcare systems, including the vaccine safety data link that's already been mentioned by Rich Platt, PRISM, which is looking at H1N1 vaccine, OMOP, which I'm going to talk about, and Sentinel. So there are a variety of these systems are being set up. They're trying to use data, real-time, existing healthcare data in various ways. I'm going to talk a little bit, if that's okay, about how these are structured. I'll go really fast. PRISM, you already heard from Rich Platt. So they're comparing selected events during the post-immunization window to historical and personal controls. So you can easily find the data on who's been vaccinated, and then you can set up different events that you're looking for in the post-vaccination period and compare those to what's going on historically. So that can very rapidly yield information that's of extreme interest to whether there's an unusual reaction to a vaccine. OMOP is the observational medical outcomes pilot that's going through the Foundation for NIH. And that's a fairly complex and ambitious enterprise. It's both assembling commercial data into a central database where then we can do a lot of methods development and methods analysis, as well as extended partners where the data is run behind their firewalls. And the focus here is on the data model. You heard about the data model from Rich Platt and from others. The focus is, can we build a data model that will, across all these disparate data sources, so that we understand what each data element means in each of these systems or databases. Okay, and then methods to query this data once it's put into the data model. And then for OMOP is about drug safety outcomes primarily. And so we've defined known drug and health outcome of interest pairs, such as fluoroquinolones, tendon rupture. Okay, and we're going to look in all these databases, both the distributed and the centralized, with different methods and see how well we can find things that we already know about. So it looks like this. We have a centralized research lab where we've put the commercial data. We have some research core partners that are healthcare systems, and then we have extended partners who are going to do it behind their different firewalls in a separate type of manner. Okay. So the common data model, though, I think this is important for the discussion we've been having. It's a single data schema you can apply to disparate data types. So this system, and this is what the last panel was talking about, this healthcare system collects the data this way, another system collects the data this way, okay? But with the common data model, you can match those elements up. You do that once, and then you know how they relate to one another. And so we also are working on, in OMOP on standardized terminologies so that we have a consistent data transformation when we move the data into the common data model. So this allows you then to do repeated analyses against all these distributed data sets because you're using a common data model. And so you don't have to transform the data over and over again on a one-off basis for each new analysis you're going to do, at least in theory. And what OMOP is going to do is test all these theories. So we're also developing the query tools. In fact, there's a OMOP Cup that's running, that's a competition for the best methods to, against the standardized data set that is being made available. We're looking for various analysis methods. So the common data model is not combining data sets into one big data set. Okay, the common data model is a way of using distributed data in a way that you have more reliability. It is not trying to force claims data into an EHR database. It could use either, okay? And we're trying to also develop a graphical user interface so that we could create those structured queries against the common data model. So that's in the methods part of this. I'm sorry if you can't see this very well, but you can listen to what I'm saying. So the schema, though, is that we have these data elements we're talking about, and OMOP is for drug safety observations. So there we're looking at the period the patient was observed under, the drug, the condition, the observation that was done, any procedures, visits, and then this outcome of interest, this health outcome, which might be, say, tendon rupture, or a whole list of other outcomes that are known to be associated with a given drug. And here Rich already presented these, but these are different drug outcome pairs that we're looking at. To standardize all this, though, in the terminologies, for example, for drugs, we have some standard drug terminologies, RX norm, that's already accepted, and that's what we're using to put the drugs. So that's part of the data model, is you'd have a standardized name for the drug. So no matter what people called it, you would be able to transform it into a common name. So basically what happens is you have all kinds of ways of capturing the data at the top. You work with people at their sites to transform, and you pay them, right? So somebody has to pay for this. Okay, you pay them to transform the data into a common structure, and then you can run multiple analyses against that structure. So, and we hope, as everybody's been saying, to have systematic learning, in this case about drug safety activities from setting up this sort of laboratory. OMOP is not intended to find new knowledge about, to find new knowledge about new drug event pairs. It's really to find the best methods and the best data model that then could be applied by others. Okay, oops. Okay, the Sentinel, which Mark asked me to talk about, is we're trying to develop an active electronic safety monitoring system for medical products at FDA. And we have a prototype that Rich Platt already alluded to, a coordinating center with distributed data sources, and that they'll also be developing a data model and then be testing methods. That, because that's under an FDA contract, that'll be a real-time example. We can actually run new signals against that system and see what we find. Okay. And then we have a partnership internally with the federal government, with CMS, VA, and DOD to identify the same thing, medical product adverse event pairs, and see how we can do data mining within each of those systems to come and see what we come up with. I want to have one final point here in my final minute, okay? One of the issues that's only been alluded to, but I think is one of the most important issues that we're going to have to face, is okay, we can make the data model and everything, but how do we know that reliable information was captured from the get-go? In other words, if the raw data isn't any good, transforming it isn't going to make it any better, right? In pharmacoepidemiology, this is a health outcome. Classical epidemiology, you do a case definition, and then you have all these elements. But if the doctors or the healthcare workers out there haven't recorded the information in a way that would meet the case definition, you're not going to find it, all right? Pharmacovigilance, we call it an adverse event. In the emerging science of genomics, you can't just have you can easily write down the genotype information in a medical record, right? But what about the phenotype? Okay, if the phenotype or what is actually going on with the patient isn't captured correctly, then you're not going to be able to make that genotype-phenotype linkage that you're looking for. In meta-analyses, now there's much more interest even looking at cumulative clinical trials. And there, if the data are not collected in a standard way, it's very difficult. And we know we do this all the time at the FDA, put the data together into an organized format and perform that larger analysis, which can be extremely informative. So the challenges are very similar, as everybody's been saying, for effectiveness outcomes, for quality of care, whatever you're looking for. And so the common themes, I think, with this new infrastructure that's going to be built for all of this is perform analyses at the site of the data owner. Do not create a centralized data set. And I think that's been said enough already, probably. Build analytic capacity and data standardization at the sites. This means giving people money so they can develop infrastructure, data infrastructure at their site, and as this cumulative improvement, say, in data structure and data elements occurs, they're able to implement it at their site. It's not something that's imposed externally. how do we integrate this standardized data capture with the medical workflow? I know CMS did a small experiment in this, and I heard from Peter Bach about, and it's more difficult than you think. If you want more detailed phenotypic information about your patient, you're going to have to do work at the site with the doctors, with the healthcare workers, to help them in their workflow to capture that information in a rational manner. So in some, capacity building at the sites will be needed if we want to get this to a higher level, although I agree with Richard Platt and others that there's a tremendous opportunity that's emerging right now. We'll be able to learn a tremendous amount without capturing additional data just from the data that we have right now. So, sorry, Mark, that was too long.
Janet, thank you very much. And now I would like to turn to Carolyn at ARC. Carolyn, obviously you wear multiple of these secondary use hats already in quality improvement, in comparative effectiveness research, and so on. So looking forward to hearing your perspective on these data structure and these data and infrastructure needs, and also if you could comment a little bit about where things are headed in the federal government with ARC's role in the Federal Coordinating Council for Comparative Effectiveness Research, maybe how this all can fit
That's
together.
a lot to do in 2 minutes.
That's
I'm
right.
just kidding. First, I want to thank Mark. I want to thank you and your colleagues for doing this, because I think this is incredibly important. It reminds me of the time I told the former editor of Health Affairs that data aggregation was the central issue. And, then I had to rouse him from the coma that he went into immediately. I couldn't quite make it concrete enough. Mark, I think many of you know, has been a brilliant researcher in a prior life and before he came to government. But I think the quality about him that's most impressive is he's fearless. And the description you heard today about how you can keep personally identifiable data behind a very tightly a very restrictive firewall, but still learn about other applications, whether that's quality improvement, quality assessment, comparative effectiveness research, and so forth, is the result of his being completely unafraid to take this on, roll up his sleeves, and launch some pilot projects. So I just wanted to salute that work. So ARC has actually been in this business for 20 years this month, and the general theme behind the creation of ARC in late '89 was that, after all, Medicare has all that data lying in a warehouse. Can't you guys spin these tapes and understand how to find that cost without benefit that is so apparent from practice variations that we see everywhere? So in addition to supporting brilliant research done by Mark, by David Blumenthal, members of the last panel, and so forth, we've also been kind of in the data business for a while. So I think together with the researchers whose work we've supported, we're probably the world's leading experts in the limitations of billing data to make inferences about clinical care. We also work with states to make their hospital discharge abstracts available and to use those same databases as platforms for quality and patient safety indicators and so forth. But of course, the big news for us, and I also want to say my only visual, no slide, this is the Annals of Internal Medicine, September 1st of this year, which has 2 articles on 2 different prototypes that we funded starting in 2007 for distributed data networks. I'm not going to replicate what people said before. Let me just say that as part of the ARA investment, ARC will continue investments in this area, continue investments in registries, and some of you may have been aware that the spend plan for the Office of the Secretary's $400 million was recently released to the Congress, and some of the projects that you will be hearing more about include clinically enhanced state data for analysis and tracking of comparative effectiveness impact, distributed data networks, improving and building new registries, and a registry of registries, which I think could be a very important tool for research. So let me just turn now to some opportunities and challenges. One huge opportunity is that both the House and the Senate bills direct the Secretary to, actually the Secretary has got more instructions than you could possibly believe. The Secretary shall ... right? But one of those ... is to create a national strategy for quality. So for those of you who are familiar with the current quality enterprise and are sometimes reminded of 6-year-olds playing soccer, rest assured that we will have a national strategy. But coming up with a new movie is really, really easy and a new set of priorities, and it's a lot of fun. The real challenge is creating an operational transition from where we are today, because the bills also direct CMS to keep doing what they've been doing, but faster and more of it, and getting to rewarding quality and not just volume and so forth. So creating a transition path from that state to a better state that completely aligns with meaningful use of health IT and so forth. Huge, huge opportunity here. It's going to totally change developing quality measures from an enterprise that's opportunistic, what data do I have, to one that is strategic. We've got lots of data. Data are no longer scarce. What's the most important aspects of care for all of us to learn about and improve? And Ruth Perot, I know you're back there. I would include disparities very much as part of that, and I'm really thrilled by the work that's going on in Massachusetts to that. So essentially, at 50,000 feet, what this all means is that the delivery system becomes a platform both for discovery, what works, what doesn't, for which patients, can we anticipate new harms, and so forth, and for rapid translation into practice. And in addition to that, I think it will help us detect very important signals that today are lost. When a patient who ought to, on paper, meet all the criteria for a new breakthrough treatment fails, we don't capture that very easily. You know, it's an act of altruism for the people providing care to get that signal back to the biomedical enterprise, and we can do much, much better than that. But at the same time, that suggests that there's many more participants in the research enterprise. Okay, we have to do much better than what I heard a former colleague at NIH say, that doctors are just going to have to get used to collecting a lot of data that doesn't have anything to do with patient care. I don't think so. In fact, a very recent example I heard about was that some measure developers have submitted some measures for endorsement to the National Quality Forum, and they have actually e-specifications for building them into electronic health records. But when tested in another system, they didn't work. And part of the reason they don't work is that the docs don't use all the functionality of electronic health records. So that gives Dr. Blumenthal a big challenge. Does he tell docs to get with the program, or does he encourage vendors to make it easier to get the information from using what some people sometimes refer to as Epic Lite? I want to reinforce everything in terms of specific challenges, but also opportunities that Alan Garber had to say about common data formats and about methods. The real question facing us in the 21st century for research is, with more better data, does that change the threshold for when we have to have a clinical trial and when actually learning as a byproduct of providing care is actually as good and a whole lot faster? That, I think, is going to be a really, really important question. So in addition to the data, we've got to be making investments in continued methods. And I would include actually not just for researchers, but also the peer review function, because it's been my observation that a lot of journals don't appear to have a robust cast of reviewers. And it doesn't matter whether it's a journal or something else that's sort of certifying the quality of the work. You need people who know how to ask the tough questions about the work that was done and why did you do the analysis this way or operationalize the variables that way and so forth. A huge, huge challenge, but one that I think is very, very exciting, is one that Mark highlighted early on, and that's incentives for participation, or as I would say much more concretely, what's in it for me? Why should I be part of this? Okay, researchers have long looked at Kaiser and places like that, Harvard Pilgrim, look at all that data. Man, I could do such great things with that. It's a very different kind of enterprise that is not quite so colonial, but much more participatory. And by participatory, I mean healthcare leaders, I mean the clinicians, I mean the patients, I mean people in the community. It gives new meaning to the definition of team sport. And ultimately, those collaborations have got to include health IT vendors, and frankly, IRBs and others. I was thrilled to hear about the public health practice operationalization, but I think we've got to scale that up in a really big way if we're going to get to the kind of rapid learning envisioned by many people here today, by Lynn Etheridge and others. Now, Mark, you spoke to alignment of incentives, and I'm all for that. That's always a great thing to say. I will say, though, I think we may learn a whole lot about the psychology of transparency, which I think most people would define as something that's really good for other people. To give you a concrete example, we funded a project a few years ago in the wake of concerns about Vioxx. And this was actually inspired by the idea that probably many docs in small practices didn't often report to MedWatch. I'm sorry, Janet, but I know that you're aware of that. And what we did was to create a web-based tool for reporting on both adverse drug events and medical errors. And the first thing we learned was that docs wanted regular feedback, not a surprise. I want to get something back. Are other people seeing this too? And I think that has got to be the model for the future. The docs had very, very different feelings about sharing information on adverse drug events than on medical errors. And I'll just leave it at that. One huge challenge, it seems to me, is something that the Brits often refer to as information governance, right? We are moving from a world where data are scarce, and it's very common to hear researchers say, my database. And believe me, they mean my database. To one where we've got multiple uses coming from the same set of data. So in addition to common formats, we're going to need some common operating rules. This is not a policy world that anyone had anticipated. And then finally, let me say, data will not solve all of our problems. And I would highlight two issues. One is the need to actually think about the systems improvement that go along with wiring the healthcare system. This is not to diminish the amazing work that Dr. Blumenthal and his colleagues have to do, but to say that adding on to that is going to be very important if we're really going to get some of the waste and improvement capability that we have. And the other is, you know, evidence doesn't answer all questions, and I will simply refer you to the recent debate and discussion we're having about what age you should get screened for breast cancer, and I'll leave it at that. So thank you for having me here.
Great. Thank you. Thank you very much, Carolyn. David, let me turn to you. You and your office have been very clear in both the goal of supporting health IT availability to improve patient care, but also being cognizant of all of these secondary uses or benefits of aggregated data. And so it's interesting, Carolyn, making that the central issue in healthcare reform. I think there's something to be said for that. But these aggregated data issues, and you also have a lot of opportunities for support and incentives coming up with the upcoming regulations on meaningful use, with the other activities in the Office of the National Coordinator. I would very much like to hear from you about how this all fits together with your priorities.
Well, thank you, Mark. It was great to hear the other panelists, and I'm sorry I couldn't hear the beginning of the morning conversation. Let me just take off by saying that the Office of the National Coordinator, in implementing the ARA high-tech provisions, has a number of tasks and a number of priorities. And we are very cognizant of the fact that to be successful in achieving the improved healthcare goals, improved efficiency goals, and improved population health goals that we are all committed to, we really have to lay the groundwork for that now somewhat cliched term, a learning healthcare system. It is possible to imagine many variations of learning and many sites of learning. And one of the tasks that we collectively, those of us sitting on this panel in the federal government, along with our many private sector partners, are going to have to think through, and which we haven't, I think, begun to think through in any systematic way, is what we mean by that and how it can be implemented. The vision is there. The path to implementation is just beginning, I think, to be conceived. Learning can take place at the level of individual clinicians and also at the level of individual patients and consumers. We haven't, I don't think, talked a lot about the uses of data by consumers for managing their own health and learning about their own health, but that's a very powerful use of healthcare information. It can take place at the level of a practice or an organization, at the level of a community, at the level of a state, at the level of a nation. the questions that each of those entities might ask are going to be different, and their needs are different. The types of learning that go on in a healthcare system are different. We've heard a number of them mentioned here today. At the individual clinician level, there is the need to understand and learn about existing healthcare information. What are the current guidelines? How do I do the routine things that I'm supposed to do but may not remember that I'm supposed to do? How do I improve my practice day to day, moment to moment? How do I improve my decision making? How do I use the existing data in a better way to make higher quality decisions? We talk about quality a great deal in national discussions. Mostly we're talking, though, about the quality as measured by the adherence to established processes, scientifically proven processes, rather than improving the quality of decision making, which is a much more complicated factor. How do we learn to decrease variation at the individual practice level, at the organization level, at the level of a polity? And then, of course, the uses that we've been talking about, comparative effectiveness research, enhancements of safety through post-marketing surveillance of medications, clinical research, biosurveillance, epidemiology. Multiple actors, multiple uses. Is there a common pathway to creating and making possible all these uses? And by the way, we've been trying to move beyond the term secondary use because it implies that there is a primary use that's more important. So we've been experimenting with the term enhanced use of data. That might be better than aggregate use or aggregate data. Enhanced data maybe better than aggregate data. So the first thing to note very clearly is that this has never been done. People point to other health systems around the world that have much more robust electronic health systems than we do, but none of them do this. None of them are models for what we are talking about at this discussion. We're pretty confident, we could be wrong, but we're pretty confident that it starts with creating a robust electronic infrastructure. You can't collect the data unless it is collectible, and it's too difficult and costly to collect it in paper form. So the wider this electronic infrastructure is, and the more fluid the information is within that infrastructure, the further we will be toward these multiple learning purposes that we all support. It would be nice, as we built that infrastructure, if we had some sense of what the priorities were for learning. I think there are some implicit in the high-tech law, but they're not called out explicitly for emphasis. It does matter what you want to do when you build an infrastructure. It matters at a fine-grained level, not just at a conceptual level. But it's also clear that in addition to having that infrastructure, we need standard definitions of information and data. And that is clearly one of the responsibilities that we have at the Office of the National Coordinator. We have to, as a matter of fact, by the end of this calendar year, produce a regulation with standards and certification criteria for electronic health records. And one of the clear requirements for that is that we define the data elements that have to be recorded in an electronic health record. And we are hard at work on that as we speak. And we got a lot of advice on that from a FACA committee, a Federal Advisory Committee, called the Health Information Technology Standards Committee, which is public and available. You would be amazed, by the way, at how much controversy there is over how to define data elements. As someone who did not come out of this field but was a researcher, this was one of the things that I found absolutely stunning about my new responsibilities, is the level of intensity that people feel about how to define data elements. But I think that's possible at a certain level. We won't necessarily be able to define all the elements that should be in the data collection. that is very much dependent. What you need is very much dependent on what you want to do with it and what the problem is that you want to solve. I agree totally with Alan that it would not be a good idea for the federal government to define anything about research needs, unless perhaps it is about how you identify patients who might be useful in a recruitment effort for clinical research. I think the other thing we can do is create a framework for interoperability so that information can flow within the system. And the third thing that we can do is create a framework for privacy that supports trust in the learning healthcare enterprise. And that can't be overemphasized. Now, we have a series of tools to do those things. We have this meaningful use program, a set of incentives that will give physicians and hospitals and other healthcare providers enhanced Medicare and Medicaid payment if they become meaningful users. To be meaningful users, their electronic health records have to be certified against criteria that are based on standards. So